Good evening, everyone, and welcome to everybody on the behalf of Society of Medicine, Fetal Medicine. I invite you all to participate in another exciting webinar in our Next Gen series. In the Next Gen series, we have young experts who tackle niche topics and give their fresh takes. And today we are all eagerly awaiting to listen to their fresh take on fetal phase. And as you know that we had fetal phase part 1 last month, and it had a huge response. And today again we have a lot of people participating as delegates and which are eager to listen to the young experts. So without further ado, I would like to invite the first speaker, Dr. Rachita Ramamurthy. I think she needs no introduction. Some say that imaging runs in her blood, and some say that she has an autosomal dominant mutation, which makes the fetal medicine expertise, you know, run in her blood. So I think it is her relentless hard work and dedication, which makes her the next gen expert. And today we are all eager to hear from her on fetal eyes. Let's see what her insights are when she tackles fetal eyes. Over to you, Dr. Rachita.
Thank you, Dr. Alok, for that very colorful introduction. And I'll just start sharing my slides. Let me turn off my video so that maximum bandwidth goes to the PPT. Okay. Okay, so we're going to continue the phase series with a talk on the fetal orbits. So we know that the orbits are an essential part of the fetal phase examination in our mid-trimester anomaly scan. They're in fact part of the first trimester anomaly scan itself. The NT scan itself, we need to document both orbits, the presence of the orbits and also the lens. But in this talk, I'm going to stick to the second trimester assessment of the eyes because it's a short talk, and I'll describe the normal appearance of the orbits. What are the characteristics that we must look for, what we should document, and what are the anomalies that we can face when we come to the orbits. So coming to the second trimester, mid-trimester anomaly scan, the screening scan that we say 18 to 24, 23 weeks, the orbits are one of the sections that you have to save in the fetal phase. And how do we document the orbits? We can do it in the axial sections. And the axial section itself, you can take in 3 different ways. You can take it with the face pointing up, meaning the probe is here, the footprint of the probe is here, and the face is pointing towards the probe. So you get an axial section through the 2 orbits with the entire orbit seen on either side of the nose and also the lens seen well. So this, I feel, is the best way to document the orbits, where the face is directly pointing up, axial section, both orbits seen symmetrically. You can also take axial sections when the face is turned to the side or in an oblique position. This is the face to the side where the beam is passing through the side of the face. Okay, so here the beam is tangential. So you're not going to see the lens very clearly in both the orbits. You might get the near lens well, but the far orbit, the lens will be obscured. And the other way is in an oblique section where, again, you will still get both lenses, but you won't get the entire posterior capsule very nicely. But okay, you can see both the orbits and you can see the symmetry. The last way is to do it on a coronal section where, again, you're cutting the face through the lateral surface of the face. The probe is up here and the beam is passing through the lateral side. You can get both orbits the size, and you can also get the lenses, but you'll have to go quite anterior. So you're not seeing the entire diameter of the orbit because you're going to cut through here. The coronal section is going to go through here to get the lenses in a ring type of appearance that will be towards the anterior end of the orbits. So to look at the lens better, you may want to do this, but again, the far orbit and the far lens may be obscured in shadowing. So I would say aim to get this sort of a view with the face up, axial section, both orbits nicely seen throughout their extent, and the lens is also well seen. The checklist for us in the mid-trimester is that both orbits should be present and they should be of equal size. The interorbital distance should be equal to one of the orbits to fit in between. So just by eyeballing, pun intended, you're eyeballing the eyeballs. So just by subjective assessment, you should be able to fit a third orbit, a third globe in between these two orbits, and that is fine. That's enough. You don't need to really measure each globe, measure the interorbital distance for a routine scan. And then lastly, we must not forget to actually document the posterior capsule of the lenses. They should be present in both orbits. So that is the checklist for the orbits. Pretty simple. One axial section like this with face up is more than enough. Before I move on to the next slide, can somebody disable annotations? When people touch the screen, there are dots and lines coming across the screen. Let me see if I can disable annotations. Yes, I've disabled annotations and I should be able to clear all also. Clear all, clear all. No, I'm drawing something. Okay, that's fine. There's one dot that's remaining there. We'll forget. Okay. So that is how we document the orbits routinely by ultrasound in the mid-trimester. If we are wanting to do a detailed study of the orbits, what are our indications? So if we are seeing on a routine screening, if we see a abnormality in the lens, it could be an absent lens, it could be small, it could be large, it could be a different position. Okay, the orbit itself could be variable in position, size, and the lens itself could be abnormal. So in a routine scan itself, we could find abnormalities. We may want to study the orbits in detail if we expect orbital anomaly because of other anomalies in the fetus. Say, suppose we see holoprosencephaly. We know that the orbits will be abnormal. It will be either hypothyroidism, hyperthyroidism, etc. If we see lissencephaly in the brain, we have to check the orbits carefully for any retinal dysplasia. If we see septal agenesis in the brain, we have to look at the orbits carefully, specifically retroorbital optic nerve, optic chiasma, etc. So when we expect something in the orbits, we are going to go more in detail beyond the screening. And of course, if there's a past history in the previous pregnancies, if there's a family history of an orbital abnormality like a cataract, like a microphthalmia, again, we're going to be very careful in examining the orbits and we're going to measure the orbits even if subjectively they look normal. So coming to the measurements, we have to take the ocular size and interorbital diameter, either when we are subjectively suspecting something abnormal, or if there is a previous history and we want to be sure that the orbital measurements are normal. So this is the chart that I use in practice. It's a pretty old chart, 1988, Jonti et al. Has given us the nomograms for the binocular distance, which we really don't use. Interocular distance is between the two orbits, and the ocular diameter, one orbit diameter. So you can use this if you would like to. And how do you measure? It's simple. For the ocular diameter, take the diameter of the orbit inner to inner, and interorbital diameter from the outer edge of the orbit from one orbit to the other in the same axial section in line with each other. So that's how we use this chart. And coming to the other details of the orbit, you can look at the hyaloid artery, which extends from the posterior capsule of the lens to the optic cup. Okay, that hyaloid artery is a normal feature up to 30 weeks of gestation. So if you're using a high frequency probe, especially a 9 megahertz, a transvaginal scan for whatever reason, you can see this artery very, very well. Should not miss anything abnormal. It absolutely is a normal embryological structure. After 30 weeks, it starts disappearing. And beyond 30 weeks, if it is still seen, then we need to worry. In the third trimester, you can also see conjugate eye movements of the orbits, where the eyeballs are moving back and forth, and you see both the lenses are synchronizedly moving back and forth, and that's called the conjugate eyeball movements, and that is something nice to notice and document as well. So 30 weeks, you see the lens again as a posterior thin, sharp line, nothing beyond that. And we can also see the anterior capsule. You can see the palpebral fissure in between the two eyelids. That's a oblique sagittal section through the orbit. You can see the upper eyelid, you can see the lower eyelid, that's the cheek. And if you do a corneal section, you can see the palpebral fissure. That's the gap between the upper eyelid and the lower eyelid. So in later gestational age, you can also see such clear detail when you do a high frequency scan of the orbits. You can also study the vasculature of the orbits. Not again essential routinely, but if we are suspecting some abnormality, you can put on the Dopplers and you can see the vasculature even into the hyaloid arteries. Some with our newer machines, with slow flow, with a power Doppler, it's brilliant to look at even these small vasculatures. Coming to MRI, we don't really need MRI in most cases to study the orbits, but how do the orbits look on MRI? These are T2 weighted images where you see the globes again on either side, symmetric. You see the entire lens. You don't see just the posterior capsule. You see the entire lens, which is a bit hypo intense. So you can see it on axial, you can see it on corneal, you can see it on sagittal. And just the symmetry and the uniform, regular outline is more than enough to document in an MRI. So coming to abnormalities of the orbits, the first thing, congenital aphakia, where the lens is missing. Congenital aphakia can be primary or secondary. In primary aphakia, both the lenses, bilaterally, the lenses are absent. It's basically a development and failure of the lens. It can happen in an autosomal recessive disorder, a FOXE3 mutation. And here the anterior chamber also can be dysplastic. In secondary cases of aphakia, it is where the lens was present earlier in gestation, but then gets resorbed due to some pathology. And that pathology could be a rubella infection, it could be an ischemic insult, and that can happen either unilaterally or bilaterally. And apart from the lens being absent in secondary cases, it can also be associated with microphthalmia. The growth of that orbit may be limited, so it can also have a difference in size. So these are examples of bilateral aphakia, where you're seeing a little bit of asymmetry of the orbital size also. One side is a little smaller than the other, and that's the abortal specimen showing you that there's no lens in the orbit. Coming to the size, the first most common abnormality we face is microphthalmia, and it can be so small that it can sometimes also be anophthalmic. So microphthalmia, as soon as you see the subjectively itself, you know that the two globes are very small, much smaller than they should be for this gestational age, and the intracranium could be normal, but you can also expect it in cases of holoprosencephaly, again rubella infection, any other serious infection can cause microphthalmia, and also some single gene disorders, syndromes can cause microphthalmia. So you can have bilateral microphthalmia, you can have unilateral microphthalmia, and you'll have to investigate the rest of the fetus very carefully, see for intracranial abnormalities, look for other sequelae of infection to see what the cause can be. And of course, the diameter less than 5th centile for gestational age is the indicator that it is microphthalmic. Coming to the position of the orbits could be too close together or too far apart. If they're too far apart, we call it hypertelorism. And here again, subjectively, you see that the distance between the orbits are very wide. And most often, this happens in a median cleft face syndrome, where there's a median cleft and the entire midline is widened. There you have the two bony orbits itself widely spaced. So you can fit more than one orbit in the space over here. And if you measure the interorbital distance, it will be a more than 95th centile for gestational age. And this is classically seen again in holoprosencephaly. When you are seeing the orbits too close together, you call it hypotaylorism. And here the interorbital distance is less than 5th centile for gestational age. Again, can occur in a median cleft face syndrome associated with holoprosencephaly, where the two orbits can even be touching each other. And of course, the distance is very, very less. And the most severe spectrum of the hypotaylorism is where the two orbits fail to cleave itself and you have one single midline orbit and a proboscis above it. That's the proboscis, that's a midline single orbit, and that is what we classically call as a cyclops. This cyclops again is classically seen in the holoprosencephaly spectrum of cases. Coming to another example of a microphthalmia unilateral, but also an internal abnormality of the orbit. You see that both the orbits here do not have the lens. So there's aphakia, microphthalmia on one side, and the microphthalmic orbit also has a retinal dysplasia. Instead of seeing a clear uniform retinal outline like this, the posterior aspect of the globe, you see thick echogenic bands, a cone-shaped echogenic band extending from the anterior serrated border to the optic cup where the retina is supposed to attach. That entire part is lifted off. It looks like a retinal detachment postnatally, but antenatally, it's not a retinal detachment. It fails to attach itself properly. It fails to develop itself properly, and that's why it's called retinal dysplasia. And that again is a sign that there could be abnormalities intracranially, especially seen in Walker-Warburg syndrome or a hard E syndrome, a case of cobblestone dyssencephaly, and you'll have to carefully look at the intracranium to see if there's such an abnormality. Coming to another abnormality of the lens, congenital cataract. So instead of seeing only the sharp posterior surface of the lens, the entire lens is looking dense and thick. So this is classic of congenital cataract. And congenital cataract is usually bilateral. Can occur unilaterally also, but usually bilateral. Most often, the causes are infections. It can happen in CMV, it can happen in toxoplasmosis. It can be familial, autosomal dominant, or autosomal recessive. It is also seen sometimes in aneuploidy. In all the three common aneuploidies, Downs, Petau's, Edwards syndrome, it can be seen. It is also a marker of inborn errors of metabolism like galactosemia. It can also be seen in single gene disorders like SLOS and Walker-Warburg syndrome, Smith-Lemli-Opitz syndrome, or Walker-Warburg syndrome. So for all of these, we'll need to do an invasive testing, an amniocentesis, to see what is the causative agent. We'll have to add a torch PCR to rule out infections. You'll have to add a chromosomal microarray to rule out aneuploidies and microdeletions, duplications. We'll have to add a whole exome sequencing or a whole exome max sequencing, where the entire entire exome is covered to pick up single gene disorders of either autosomal dominant or autosomal recessive inheritance, and inborn errors of metabolism, genes, and of course the known single gene disorders. Cataract can also occur with certain drug teratogenicity, specifically warfarin coumarin derivative usage can cause cataracts. So basically, the entire lens is thick, irregular, hyperechoic, and not just the posterior capsule, the whole substance of the lens can be opacified. The whole lens thickness, if it is hyperechoic, it can be either a diffuse hyperechogenicity or punctate echogenicity. And this is an evolving anomaly, especially in cases of infection or in cases of inborn errors of metabolism. It may not manifest earlier in the first trimester or even in the mid trimester. It can manifest in the late second trimester or even in the third trimester. And that is something to keep in mind. And if we at all pick up something like this in the third trimester, just go back to your earlier images, see if you have documented the lens well, and see if it is evolving, and then you can look for other features to say whether it is infection or not. So we have to look for other ocular signs, extraocular abnormalities like hepatosplenomegaly, intracranial calcifications, IUGR, any other features telling us that there could be infection, which is, of course, the most common cause. Normal appearing lens does not always rule out cataract. That is another thing that we must inform the couple, especially if they have previous children with problems of the lens. We must tell them that right now in the mid-trimester anomaly scan, the lenses look normal, but we don't know how they will evolve. And even if by ultrasound they look normal, postnatally, it does not indicate no cataract or perfect vision. So this needs genetic evaluation, ophthalmic counseling, and of course, invasive testing, amniocentesis for all the tests that I spoke about. Coming next to the persistent primary hyperplastic vitreous, this is when you see the hyaloid artery and the primary vitreous persisting beyond 30 weeks. This is a 34-week scan, and you're seeing this echogenic thick structure going from posteriorly up to the lens, and that is the PPHV, persistent primary hyperplastic vitreous, and that can lead to problems later on. Again, opacification of the posterior capsule of the lens can occur in such cases. Coming to orbital contour abnormalities, we could have retinochoroidal colobomas happening in utero itself. So this is basically because of incomplete closure of the optic or choroidal fissure, which should complete by 35 days of life itself. But if this doesn't complete, there's a small gap that is seen posteriorly, like a little staphylomas bulge from the posterior surface of the orbit, and that is called a coloboma. So this was a 21 weeks scan where one side we could notice a bulge from the posterior surface, but on MRI it was actually bilateral. This other side, tiny little bulge, was not appreciated on ultrasound, but it was much more clear on MRI. So for certain cases, MRI does add on information, especially with certain tiny defects like this. So the coloboma results in an nasal scleral outpouching and vitreous herniation. It's usually bilateral, and it can be associated with charge association, agenesis of corpus callosum, Vater or Vactal associations, Joubert syndrome, Walker-Warburg syndrome again, Aicardi syndrome, renal colobomas, etc. And clinical spectrum, it is a whole huge spectrum. It can result in minor visual defects or complete blindness and poor vision if the fovea is involved. And that we, of course, cannot ascertain antenatally. We'll have to ask the neonate to be tested postnatally. Coming to orbital eyelid abnormalities, you could see ectropion, where the eyelids are edematous and everted, and this can happen in congenital ichthyosis, where you have the classic harlequin facies, where there's a lot of skin edema and the eyelids are also edematous and everted. And of course, that is the classic fish mouth appearance in a ichthyosis. We could also see eyelashes, and this was a case of a septal agenesis. There was a cardiac anomaly as well. There was overlapping digits and a hooked index finger. And when we saw the orbits and the eyebrows and the eyelashes, there was multiple long hairs that were seen over here. That is hypertrichosis, very, very long eyelashes, and a monophorus, where the two eyebrows are joined across the bridge of the nose, that is synophorus. So this is hypertrichosis, and that's classic of Cornelia de Lange syndrome. So all of these cases I have borrowed from Dr. Ramurthy's collection, of course, and these are extremely rare cases. So I don't think we must all expect to see them in our practices, but it's nice to know how much ultrasound can show us. And if you put the entire picture together, we get our answers. Coming to abnormalities adjacent to the orbits, we can have a dacrocystocele. And this is quite common actually, where the tear gland pouch is dilated. So this happens when there is an imperforate valve of Hassner in the nasolacrimal duct. So there is mucinous secretion that distends the duct, and most often it is seen in the third trimester. It can extend up to the nasal cavity, and sometimes it can be obstructive also. It is most often sporadic. It can be unilateral, most often unilateral in 3/4 of the cases, sometimes bilateral in 1/4 of the cases as well. And classically, it's seen as a thin-walled cyst at the medial canthus between the nose and the medial surface of the orbit. This cystic lesion that you can see, that's the classic dacrocystocele. Sometimes there could be debris also inside, but most often it is clear fluid containing. This is actually a benign condition, very good prognosis. Postnatally, it may regress on its own with a few washes, or sometimes a little bit of a pressure and puncture may be required to drain the dacrocystocele. Coming to the retrobulbar compartment behind the eye, we can see the optic nerve. That's with the eyeball movement. You can see the optic nerve also moving. Better seen, of course, in the later gestational age. And of course, you can see the optic chiasma when you go down from the base of the skull in the circle of Willis. We'll see the nice X-shaped or a head-shaped structure with the optic chiasma. This need not be studied again routinely, but we can look at these structures when we are seeing a case of septal agenesis. We can even measure the optic chiasma, we can measure the optic nerve, we can even measure the optic tracts. And there's a whole study, one of the latest studies that has gone through multiple cases and documented nomograms. This was 2021 study by a Chinese group, and they've given all sorts of nomograms for the optic nerve, optic chiasma. That's the chiasma, that's the nerve, and that's the tract. All measurements have been given from all gestational ages. And this is an open access article, and you can, of course, download it if you would like to use it. So in cases of an septal agenesis, we want to measure the optic chiasma, look at it for presence, look at the nerves, look at the tracts, look at the chiasma, measure it, and make sure that it is in the normal size for gestational age, but still that does not rule out septo-optic dysplasia. If we don't see the optic chiasma itself, or the optic chiasma is very small, then that adds on to our suspicion of septoptic dysplasia. But a normal chiasma does not rule out a septoptic dysplasia, and that is something to be kept in mind. The same prognosis of 1:4 continues, where in 4 cases of septal agenesis, 3 cases may be truly isolated and may have good prognosis, but one of the cases can still turn out to be septoptic dysplasia and will need postnatal assessment for the pituitary axis and the hormonal line of the triad. So I've shown you a series of abnormalities of the orbits, and I've tried to include few common conditions and few rarer conditions, and what is the checklist that we need to keep in mind. And if we are making sure that we are documenting both the orbits, size, symmetry, and the lens echoes, I think that is good enough for our screening. And I've also told you where we need to pointedly study more about the orbits. Thank you very, very much for a very patient listening.
Thank you. Thank you, Rachita, for this insightful, eye-opening, and sharing this extensive library of cases with us. This was truly amazing.
Thank you. Thank you, sir.
And hope to see you soon at Basic One.
Thank you. There are, I think, a few questions. Should I take them now or at the end, sir?
No, I think we will take them at the end.
Sure,
okay,
sure.
Please join us.
Sure.
Okay, so the next speaker is not only a astute fetal medicine expert, he is an artist at heart, and his canvas is the ultrasound machine. His favorite genre is 3D imaging. He is going to mesmerize us with his mind-blowing images and he'll be speaking on fetal ear and tympanic rings. So over to you, Alpesh. Alpesh is a practicing radiologist and fetal medicine consultant from Vadodara, Gujarat. And I especially asked him to speak on fetal ears and tympanic things because he has an amazing collection of cases. Over to you, Alpesh. Please share your screen. Alpesh, please go full screen. Yes, thank you. Unmute yourself.
Am I audible?
Yes.
Yeah, thank you for your nice introduction. And at the outset, I would like to thank Dr. Khurana sir, Dr. Bimal sir, Dr. Mohit sir for giving me this opportunity. So my topic of presentation is fetal external ears and tympanic rings, normal and abnormal. So the ears are an auditory sense organs and they play a role in hearing as well as in the balance and physical orientation of the body. Abnormal ear development can be associated with facial dysmorphism, many genetic syndrome, and hearing loss. But fetal ears are not routinely evaluated in prenatal anatomical screening. Ear malformation are one of the main features of many syndromes, commonly Treacher-Collins syndrome, golden heart syndrome, Krausen, Eppert, and Klippel-Feil syndrome, or even in aneuploidies, common trisomies like trisomy 13, 18, 21, and 18q syndromes. This is the normal anatomy of the external ear as we see in the postnatally. So this is the common ones we can identify the tragus, antitragus. This is the helix, antihelix. The fossa between these two is the scapha. This is the triangular fossa, and this part is the lobule. Coming to a brief embryology of the ears start developing at about 4th week with the tissue condensation at the first and second pharyngeal arches. Later on, there is bulging of the tissue happens, which are known as the auricular hillocks on from the first and second pharyngeal arches. Later on, they fuse to form the final architecture of the external auditors. To note that the ears develop in the neck region. This is the hard prominence. So ear develops in the lower neck region, and with the development of face, especially the mandible, it move upwards. So as we know that with the poor development of mandible, say in micrognathia, it is usually associated with low set ears. So this is a case of autocephaly I have taken from Viswag. So autocephaly is the form in which there is a agnathia. There is no formation of the mandible. So the ear develops in the neck region and touching each other. This is known as synorchia. One more important thing is neural crest cells give rise to external ear formation as well as other organs like conotruncal tissue and thymic tissue as well as the craniofacial uh, uh, bony tissues. So external ear defects often occur in combination with abnormalities in these structures, such as face, skull, and heart. Coming to the brief embryology of the development of tympanic ring, at about 10 weeks of gestation, there are 4 ossification center develops for the tympanic ring development. At about 19 weeks, it completely ossifies, so we can see it in on the sonography as well. So this demarks the junction of the external ear and the middle ear. So tympanic ring is responsible for normal development of the middle ear as well. So this is in the infant, there is complete formation of tympanic ring and it merges with the temporal bone. What the guidelines say on the ear assessment? Many guidelines like in our society, SWAG and as well as AIUM, they say that location and configuration of external ear is required only in specific clinical scenario and they does not form a part of routine anomaly evaluation. But if we do not image routinely ears, we may have the situation like this. This was a case shared by a friend. Here, the anatomy was normal. There was no anomaly. The pregnancy was uneventful, but at birth, there were bilateral anosia. So it is prudent to look for the ears as a for a diagnostic tool because any problem in surface anatomy like clubfoot cleft, microtia, anotia, ambiguous genitalia, limb reduction defect, they draw immediate attention of the parents and relatives, and they create anxiety, anger, and sometimes violence also. Nowadays, violence is very common. It hardly takes 10 to 15 seconds more when you are imaged in the right position and routinely. So it's always better to have pattern recognition of the ear and gain more confidence. And it is preferable to identify and address potential issues promptly rather than overlook them and face negative consequences. Coming to ultrasound evaluation of auricle and tympanic rings. So during first trimester, we can also evaluate for the pinna on both the sides. This is the axial with the dorso anterior. Here we can see developing tympanic ring as well. This is a dorso posterior position here with the assessment of the orbits and the retronasal triangle. On the either side, we can see the ears as well. So these are the sagittal sweep on both the sides, side by side sagittal sweep with the dorso posterior and the dorso anterior position. Here we can see the pinna on either side, but here we can see the size, but anatomy is not very well clear in the first trimester. In the mid second trimester and third trimester, we can see the anatomy very well. Okay, so this is the dorso posterior position with the sagittal sweep on either side. We can see both the ears, we can look for the normal morphology as well and the size. So this is with the dorso posterior normal supine position. Here also we can look for the ears as well. This is the coronal sweep. Here we can see the pinna on either on one side. Here we can see only the measure only the size, not the morphology. But to note that the upper margin of the pinna should be at the level of temporoparietal suture or the squamous suture. If it is lower than that, we can assume or we can suspect low set ears, and we can confirm it in 3D imaging as well. So this is a 2D imaging still image of the pinna. Here we can see the normal morphology of the ear. This is the helix, antihelix, triangular fossa, scapha, tragus, antitragus, and the lobule. And the third trimester, we can also see the external auditor canal as well. But for evaluation of the morphology is based in the 3D ultrasound. At 9 weeks also, we can see the small ear in the level of the neck region as the face develops with the mandible development. This is at 12 weeks, transabdominal. Here we can see the ear. This is 13 weeks with the transvaginal scan. The morphology is better seen. But during first trimester, we should not comment. They are relatively on the lower side. Okay. So to confidently say as a low set ears, you should comment it after 15 weeks. So as the gestation advances, the features and the morphology becomes very much clear. Coming to the evaluation of tympanic ring, this is the dorsal anterior position and the axial sweep. We can see both the pinna, and we can see echogenic rings on either side with the malleus. Ossicles are also seen. Here I have kept SRI off so we can see the bony structures very well. But best sweep is we have to turn the VCI in the skeleton mode off so we can see very nice tympanic ring on the either side with the internal middle ear ossicles. This is the 3D rendering image and the axial plane on the either side. And this is the oblique orientation rendering. We can see the tympanic ring behind the auricle. This is the corresponding abortus image. So this is a very short video. In the dorso-posterior, we can see on the axial scan, you can see both the pinna, both the tympanic ring. Now rotate the probe to the 90 degrees and sweep on either side, and we can see the both pinna as well. So this video, in about 15 seconds, we can complete the ear assessment. Coming to the abnormalities of the external ears. So abnormalities can be in the size, in the position, rotation, shape, and preauricular tags. I will not go into details of shape because it's very difficult to assess on prenatal ultrasound. Coming to the size of auricle, the size length is measured in the craniocaudal fashion in the maximum diameter, and in the width is measured from the inner side of the tragus to the maximum width. The nomograms are available, but the simple rule of thumb is the ear length is about 1/3 of the BPD. So that is your rule of thumb if you don't want to look at the nomogram. Coming to microtia, it simply means it's a small and usually malformed pinna. It is the second most common facial deformity after cleft lip and cleft palate. In about 60% of the cases, they are isolated, or in about 40% of the cases, it's a part of syndrome. Regardless of etiology, whether it is isolated or with a part of syndrome, the majority cases are associated with conductive hearing loss. Coming to grades of microtia, in grade 1, the ear size is small, external canal may be narrow, but the structure and ear shape morphology is otherwise normal. In grade 2, ear is small, some components of the pinna are missing, shape is abnormal, but we can still make out it is a ear. In stage grade 3, there is only a small tissue in the region of the ear, or it is also known as peanut ear, and it is typically associated with atresia of the external auditory canal. And grade 4 is the most extreme and rarest form. It is also known as anotia. Microtia and syndromes. It is common in trisomy 21, 18, and 13, trichorcolin, golden hair, charge, and retinoic acid embryopathy. Coming to ear position, how to assess the ear position, whether it is normally placed or not. Simply draw a line from outer canthus of the eye to the inion. The ear upper margin of the ear, external ear, should touch or should cross this line, then it is considered as normal, or it should be at the level of squamous suture. So what are the syndromes associated with low set ears? Common are aneuploidies like trisomy 18 and 13, Noonan syndrome, Dijk's syndrome, Craigduchat syndrome, porpidylation, and fragile X syndrome. Coming to posteriorly rotated ears, how to assess for the rotation? So draw a line, vertical line, parallel to the frontoparietal suture, and draw a second line crossing tangential to the uppermost anterior part and inferiormost anterior point, and draw a line and measure the angle in between. It should be less than 20 degrees. But this angle, if it is more than 28 degrees, then it is considered as posteriorly rotated ears. Most often they are isolated variant, but it is commonly seen in Noonan and Turner syndrome. Coming to preauricular tags, tags are usually nothing but the outgrowth of the skin tissue arising from the first branchial groove. It can be located anywhere between the ear and the angle of mouth. It is the most common malformation of the ear. It is found in about 1.5% of the population. Most cases are isolated, but it may occur as a part of generalized syndrome. So there is a long list of syndromes, but the common ones are the brachio-otorenal syndrome, oculo-auriculovertebral spectrum, cat-eye syndrome, 4p deletion, 5p deletion, and 11q deletion. Coming to tympanic ring dysplasia, tympanic ring dysplasia is strongly associated with microtia, congenital oral atresia, and ossicular defects. What is congenital oral atresia? In which external auditory canal and tympanic membrane are replaced by bony or thickened membranous plate. It is unilateral in about 3/4 of the cases. Malformed tympanic ring or tympanic ring dysplasia or aplasia, it is associated with syndrome which affect the development of first and second brachial arches like trichorcolin syndrome, brachio-otorenal syndrome, mandibulofacial dysostosis, hemifacial microsomia or golden hair syndrome, or even in retinoic acid embryopathy. This case I have taken from this textbook of ultrasound of prenatal brain. Here the right ear is normally seen, where on the left side there is a grade 3 microtia. This is in the 2D imaging. Here we can see there is dysmorphic left ear. And when evaluating the tympanic rings, the right tympanic ring is very nicely seen. whereas here in this case it is absent on the left side. So whenever we see grade 2 or grade 3 microtia, always look for tympanic rings. So important point to note is meticulous ultrasound examination should be done to look for additional facial malformations like asymmetry, micrognathia, cleft lip and cleft palate, and ophthalmic abnormalities, cardiac abnormalities, renal abnormalities, and skeletal anomalies. Genetic consultation and investigation should be offered in such cases. So we will see few of the cases of ear malformation. This is a 23-year-old female came to me for a routine anomaly scan at 23 weeks. Here we can see both the ears are very small. On the left side, the ear size is small, but with the 2 preauricular tags. This is the 3D rendered image showing preauricular tags. On the crania, we can see bilateral choroid plexus cyst, strawberry-shaped skull, wide CSP, megacisterna magna, dysgenesis of the corpus callosum with the thick rostrum and the genu, and there is a very small omphalocele containing only bowel. So this is omphalocele minor. To note, when I was evaluating with for the orbits, here I could see there is a prominent eyebrows and long eyelashes as well. In the hands, on the right hand, there is a pointing finger noted, and there were bilateral club feet. Couple opted for the termination of pregnancy, and here it confirmed our prenatal ultrasound findings. There is a pointing hook finger, prominent eyebrows, left side preauricular tag, bilateral microtia, bilateral bottom feet, and the abortal genetic testing was done, and it confirmed the diagnosis of trisomy 18. Coming to case 2, so this is a micrognathia corresponding 3D rendering image showing the small chin, and in the VCI skeleton mode we can see there is a microretrognathia. So we have to look for the ears now. So here ear is located at low set ear at the level of angle of the mandible. As I said earlier, always look for the cardia as well. Here we can see the dilated coronary sinus and an extra vessel in the 3-vessel trachea view suggesting bilateral as you see. This couple opted for termination and did not want any invasive testing. Coming to case 3, on the right side there is a small preauricular tag. On the left side, the ear morphology is normal. To note that the lobule part is larger, upper 1/3 is appearing smaller with the small helix and antihelix. This is ongoing pregnancy. Coming to case 4, primary 28-year high BMI patient and conceived with ART. This is case given to me by Dr. Firoz Hoover. So here we can see there is a well-defined preauricular tag on the right side. This is a very nice 3D rendering showing the preauricular tag. Also, there is a long philtrum and micrognathia. On the assessment of left ear, here the left ear is seen at the level of angle of mouth, and it is very low in position. So the couple was advised invasive testing, and on the microarray, it was found 15q11 duplication, which is likely pathogenic. Then termination of pregnancy was opted. Here we can see the preauricular tag on the right side, long philtrum, micrognathia, and this is the low set deformed left ear at the level of angle of mouth. So what is duplication 15q syndrome? It's a developmental disorder which develops difficulty in speech and language development. It can give rise to autism spectrum, ADHD, and there will be difficulty in walking and sitting due to lack of motor skill development. What are the typical facial features in this syndrome is downslending palpable features, short, upturned nose with anteverted nares. There can be long philtrum, micrognathia, and low set ears. Coming to case 5, this case was given to me by Dr. Alok Varshney. During anti-scan 12 weeks, 4 days, there is a very a high NT about above 6 millimeter corresponding 3D image. This patient continued pregnancy. At 20 weeks, there is a persistence of nuchal fold thickness. In the heart evaluation, four chamber appeared normal, but there is a narrowing of the pulmonary artery. And on the surface rendering, we can see the ear is low set and rotated. So in axial, we can see also there is a protruded ear. And on the surface rendering, we can see low set, posteriorly rotated ear, which is typically found in Noonan syndrome. So this was a case of Noonan syndrome. Coming to case 6, this is case given to me by Dr. Rohit Sangani. The anatomy, there was no other anatomy than this. There is a globe of tissue on the right side. So here we cannot find any normal morphology of the pinna. On the left side, there is a normal external ear, and on the right side, there is a globe of tissue is seen. This patient continued pregnancy as there was no other anomaly, and here it confirms the prenatal diagnosis. Coming to case 7, 26-year-old lady, G2P1, referred to me for second opinion on previously diagnosed dendivocal malformation and ventriculomegaly at 28 weeks. So here we can see bilateral pulpocephaly with the absence of CSP and high riding third ventricle. But the cerebellum appeared normal with the normal vermis, but we can see there is a fluid space there. So on closer evaluation, I could see that the left cerebellar hemisphere is compressed by this cyst. So I went for transvaginal sonography and it confirmed the diagnosis of left-sided arachnoid cyst. When I was doing coronal sweep for the corpus callosal agenesis, we can see the Bull's horn sign, but at the level of parieto-occipital suture, at the level of parieto-temporal suture, the ear is not there, it is very low. So I did a surface rendering of the ears. Here I can see bilateral low set and posteriorly rotated ears. In the heart evaluation, there is echogenic intracardiac foci and there is a mal-aligned VSD. In the limbs involved evaluation, here we can see in the right hand, there is a camptodactyly and bilateral club fit. In the genitourinary evaluation, both the kidneys showing hydronephrosis and there is on hydroureter on the right side and the right kidney appears very echogenic. This couple did not want to continue the pregnancy and lost to follow. Coming to case 8, this case is given to me by Dr. Varun Thakur. So this presented at 24 weeks, but the head size is more than 99 centile. And this is very markedly enlarged subarachnoid space. The cerebellum is of normal size. On heart evaluation, there is an ARSA, facial profile showing frontal bossing, depressed nasal bridge, unossified nasal bone, partially open mouth with trunk protrusion, and on the 3D surface rendering, we can see frontal bossing and depressed nasal bridge. On the ear evaluation on the right side, there is a very small ear with no identifiable external ear tissue. So this is a grade 3 microtia. On the left side, there is a normal ear. So this is a third surface rendering of the right ear showing a grade 3 microtia. And on the tympanic ring evaluation, this is the left side normal left tympanic ring. And on the right side, we cannot see any tympanic ring. So whenever we see microtia, always look for tympanic ring. So this invasive testing was advised and fish came as normal. There was no Down syndrome. But on whole exome screening, it was PIK3R2 gene, autosomal dominant, megalencephaly polymicrogyria polydactyly hydrocephalus syndrome, but it was given as uncertain significance. Coming to case 9. Here we can see the left ear is very small and dysmorphic. The right ear is of normal size. The left ear is measuring only 15 millimeters. This is 22 weeks, 3 days. On the surface rendering, we can see the left ear is small and dysmorphic, while the right ear is normal in size and morphology. So as I said earlier, look for the tympanic rings. So this is the right tympanic ring, and there is no tympanic ring on the left side. So this is tympanic ring aplasia on the left side with grade 3 microtia. There was no other anomaly in the fetus. So if I would not have a screen for the ear, I simply would have missed this anomaly. And in spite of positive prognostic counseling, couple after for termination, and these are the bottle picture confirming our diagnosis. So this is grade 3 microtia with ipsilateral TR aplasia. On detailed history evaluation, the lady was using a skin cream for acne treatment since 2 years till third month of pregnancy. So we concluded our diagnosis of acquired ear anomaly due to retinoic acid teratogenicity. What is retinoic acid embryopathy? It's a spectrum of congenital anomaly that occurs due to prenatal exposure of high doses of retinoic acid, most commonly isotretinoin. It is usually uh, used to treat severe acne and in some cancers. Teratogenic effects are most severe with exposure between third and fifth weeks of gestation during the period of organogenesis. The diagnosis is based on characteristic features and history of usage of retinoic acid in early pregnancy. Phenotypic features are highly variable depending on the timing and dosage. The common craniofacial abnormalities are microtia, anosia, micrognathia, cleft palate, depressed nasal bridge. In CNS, we can have microcephaly, hydrocephalus, cerebellar hypoplasia, or CC-agenesis. In cardiac, we can have conotruncal anomalies like tetralogy or transposition of great arteries or aortic anomalies. There can be thymic as well as parathyroid thymic abnormalities as well, like in Teichert syndrome. Limb anomalies are rare. There can be genitourinary anomalies as well. What is the mechanism of action? Retinoic acid act as a morphogen. So it is a signaling molecule that directs the patterning of embryonic tissue. So excess retinoic acid during early embryogenesis, during third and fifth weeks of gestation, it disrupts the critical developmental processes like it disrupts the gene expression like Hox gene, sonic hedgehog, PAX, and FGF, which is required for craniofacial development. It can interfere with the migration, proliferation, and differentiation of neural crest cells, which lead to craniofacial, cardiac, thymic, and ear abnormalities and pre-apoptotic effects. High levels of retinoic acid induce apoptosis in developing tissues like neuroepithelium, aortic placard, and pharyngeal arches. So to conclude, ear imaging should be done in every patient. High resolution sonography nowadays enable demonstration of pinna, external meatus, and tympanic ring. Examine the tympanic ring in cases of external ear abnormality. Meticulous examination of the entire fetus should be done, especially heart and genitourinary system, and offer invasive testing and genetic counseling in affected cases. Detection of auricular abnormalities in presence of other systemic abnormalities, it can provide useful information for genetic counseling as well as to narrow down the differential diagnosis. Thank you so very much for your kind attention, and thank you for the opportunity. Thank you.
Thank you, dear Alpesh. This was a very detailed discourse on fetal ears. Now, we know that this is a structure which does not even feature in many anatomical checklists. But I hope that after your talk today, more and more people are going to add this evaluation of the fetal ears to their checklist. And then we will be able to see many, many more ear malformations. And as usual, the chat box is full of questions about fetal ears. So don't go anywhere. You need to answer all of these. So I think now we should move on to our next speaker. The next speaker is Dr. Meetan Preet. She is again a scion of an illustrious family, but she is also, invited speaker at many SWOG events and in many SFM events as well. And today we I asked her to speak on some, it's a common abnormality, but it is always full of conundrums. So I asked her to speak on her on binders, facies, or the flat face. So, Mitanpreet, over to you, please.
Good evening, everyone. I hope I'm audible and clear. All right, to start with, it is indeed an honor and a privilege to be speaking on this platform. Thank you, Alok sir, and thank you, Ashok sir, for this wonderful, wonderful opportunity. Without further ado, let me take you through Roads of Contrast, a short story here of two cases, one similar diagnosis, but two different roads for the patient. Moving on to case number one. So 32-year-old priming gravida walked into the clinic and she was asymptomatic. She came in for a second opinion for Binder's syndrome. I assume that everybody knows what Binder's facies is. It is a flattened face, which is very, very obvious here. However, the rest of the fetus did not show any anomaly. A normal femoral length, no epiphyseal stippling, normal upper limbs, normal humerus, and a normal spine as well. This baby got a chance of life. This is a picture of the second trimester of the child. This is a picture of the third trimester of the child. And this is the baby after birth. The baby is doing well as of now. Case number 2. Another lady, 28-year-old, second gravida, normotensive, euthyroid, and non-diabetic, came in for a second opinion for the same reason, Binder's facies. Indeed, there was a flattened face. We did see dug-in nose, dug-in nares, and it was difficult to visualize the nostrils at that time. The baby showed short long bones, in fact, rhizomelic shortening of the femur with stippled proximal epiphysis, tarsal bone ossification, a glaring coccygeal ossification, and short stubby fingers, which is known as brachytelephalanges. This baby unfortunately did not get a chance of life. If you see the autopsy here, very, very vivid Binder's facies, very clear, rhizomelic shortening. In fact, all long bones were shortened, shortened stubby fingers, seen here as well. And if we take a closer look at the X-ray of the baby, we see a depressed nasal bridge. Yes, we see short long bones, disordered premature ossification almost everywhere in the axial as well as the appendicular skeleton, a vivid coccyx here, brachyphalanges. So this turned out to be a BCDP, that is a brachytelephalangic type of chondrodysplasia punctata. Binder's facies, one single diagnosis. One patient chose normal outcome, the other one chose termination. Why so? Because we chose to look beyond the face. Hence my topic of the day, looking beyond the profile when we are seeing Binder's facies. As far as history goes, let's go from chronological order. First, history. These are the first 3 papers, very few papers that were published on Binder's syndrome. This is in 1900s. This is the first paper that was published at that time with pictures of the babies. This was actually diagnosis in a dentist clinic rather than a fetal medicine clinic. On ultrasound, for the first time, a diagnostic triad was proposed with a flattened nose, verticalized nasal bone, and retrusion of the maxilla. How did the name Binders come into play? Well, Binders in 1962, he defined the characteristic facial dysmorphism and told us that there are 7 points that we need to remember once we are looking at Binder's facies: a short nose with a flat nasal bridge, short columella, acute nasolabial angle, periolar flatness, convex upper lip, a tendency for occlusion, malocclusion, especially in dental procedures as well as anesthetic procedures, and hypoplasia of the frontal sinus. But we all know that like fever or like ventriculomegaly, Binder's facies is not a diagnosis. It is a phenotype. Why so? It can be a familial trait or physiognomy. We have to exclude that, taking pictures of the parents right from birth to adulthood. It may be conditions that are affecting vitamin K metabolism and causing vitamin K deficiency. It may be a part of trisomy 21, it may be syndromic in nature, it may be related to chondrodysplasia punctata, or it may be in fact a Binder's syndrome, which is very different from Binder's facies. As far as embryo anatomy goes, a busy slide, but we know a lot of genes are involved in the making of the face of the baby. Most importantly here, the bone protein, which is known as matrix gamma carboxyglutamate protein. Now, this protein is vitamin K dependent. Undercarboxylation of this bone protein leads to decreased growth of the embryonic nasal septum as well as the maxilla, which causes decrease in the longitudinal outgrowth of the fetal nose. And because this is a bone protein, that is why in conditions like chondrodysplasia punctata, etc., we get disordered stippling or epiphyseal stippling and disordered cartilaginous ossification. Where does this happen? This happens in the liver cell. Now, this is the vitamin K cycle where vitamin K helps to carboxylate this protein, which again is sent into the blood for its function. What do we see on scan? If we focus just on the fetal face, we see a flattened nasal bridge, an increased frontonasal angle, which gives a concave facial profile. We see dug-in nares. A palatal line may be lost. We may not be able to see a superimposed line sign as made famous by Lakshmi Ravi and group. And there may be mildly increased leica to polyamnios depending upon the severity of the binder's phenotype in the baby. Comparing the fetal profile, this is what I came up with a lot of cases that we've seen in the last 5 years at our clinic. In fact, in North India, it is very, very common to find a binder's facies, I think, once or twice a week. So a normal profile is usually V-shaped if you take it in the right position. It turns into a C once we see a binder's profile. If we get to objectification, we see the nasofrontal angle or the frontonasal angle. The normal range of this angle is between 110 and 143, the mean value being 128. This angle is formed by the intersection of the line which is drawn from the forehead to the nasal bone and a line that is drawn from the nasal bone to the nasal tip. Mind you, there's only one article for nasofrontal angle and it is just focusing on the group between 18 to 21 weeks. Now, this is how we take a normal nasofrontal angle, 118 normal, 129 normal, whereas this is an increased nasofrontal angle signifying a binder's phenotype. If we look at the coronal section of the fetal face, that's a normal nose, normal nares, and mouth and nose. Whereas here you see a depressed nose, prominent cheeks, and from here itself I know that if I turn my probe 90 degrees into a facial profile, I'm going to get a binder's face. A narrow and long normal PMT versus a square-shaped premaxillary triangle. As far as the etiology goes, now binder's facies or binder's phenotype can be either isolated, it can be associated with a lot of conditions that I will touch on in the subsequent slides, or it may be a part of syndromes. If we take the most important vitamin in play, and a lot of hoo-ha these days in relation to binder's phenotype, both nationally as well as internationally, vitamin K and malabsorption syndromes. Now, vitamin K, we know, plays a very important role in carboxylation of that bone protein. And if the patient is suffering from a celiac disease or a short bowel syndrome, it may lead to binder's face. A very important history that I think we should not forget is hyperemesis in the first trimester, which leads to decreased vitamin K levels, which may cause vitamin K embryopathy. And a lot of deficiencies which have vitamin K dependent clotting factors, protein C, protein S, may also lead to a similar binder's face. As far as trisomy 21 goes, we all know that these babies, they have a broad and a flat nasal bridge. Any disruption in the development of the nasomaxillary complex during early embryological life will give us this broad and flat nose. Coumarin derivatives, again anticonvulsants and anticoagulants, they interfere with the action of vitamin K, they interfere with the vitamin K cycle, and hence they lead to undercarboxylation of these vital bone proteins. And similarly, last but not the least, we have SLE and APLA and other autoimmune disorders. Again, the history that should be taken. Again, an anti-Rho, anti-La antibodies, they hold importance here once we are looking at a binder's profile. All right, again, a very busy slide. Syndromic associations, where we see a lot of syndromes that show flat facies. Our job as fetal medicine specialists is to pick up these associated features because these are actually characteristic of certain syndromes, and our job is basically to make a geneticist's life easier. The mode of inheritance is also different for all of these syndromes. Okay, so with etiology in mind, how do I work up a case of binder's phenotype? What do I do to look beyond the fetal phase? Now, I've done my mid-sag view. I've seen the profile. I know it's looking like a binder's. Number one, I will objectify it. I will measure and store the angle, nasofrontal angle. Maxilla is an ongoing bone complex. You might see a decrease in the angle as the baby progresses in gestation. The normal angle between less than 143, anything more than 143, I know I'm looking for a binder's face. What do I look for further? I do a full skeletal evaluation of the child. I see all the epiphyses, including proximal as well as distal, of the axial as well as the pentacular skeleton. I see for the premature ossification of coccyx. Now, coccyx should never develop before birth. It is always a postnatal ossification. So if you're seeing the coccyx, please look at the baby's face more clearly. I see the vertebral bodies for any clefts, very, very rare, but yes, there are cases that have reported vertebral coronal clefting in cases of Binder's syndrome. And I look at the tarsal bones, the carpals for any ossification. I look at ossified nasal septum if it is there. Now again, recommendations, these are all recommendations, these are not hard and fast guidelines. Chromosomal microarray is recommended if you are looking at an isolated binder's phenotype, that is only if the face of the baby is abnormal, and a VES or a whole exome sequence is recommended if you are looking at other features also signifying chondrodysplasia punctata or maybe other syndromes that are associated with the binder's phase. Just to show you a bit of a skeletal display survey here, you see a normal fetal spine, whereas you see the coccyx here, premature ossification of the coccyx here, here as well, and here. A normal femur, normal femoral length, no proximal femoral epiphyseal stippling, whereas here you see stippled epiphyses, disordered ossification centers here, multiple disordered epiphyses here. This is a normal humerus, whereas here you see a stippled humerus. Examining the baby's foot, the calcaneum now is normally seen at around 22 to 24 weeks of gestation. If you are seeing a calcaneal calcification without a binder's face, I think it's regardless to mention it now. Before, we were mentioning it in our reports and everybody's report said that there's premature calcaneal calcification. Nowadays, we've held up our horses and we don't really mention that unless and until it is very, very early in gestation and or associated with binder's phenotype. So this is how tarsal bone ossification looks like on 3D. As far as the hand goes, normal hand, we usually do not see any carpal bone ossification, but if you are seeing carpal bone ossification like seen here, you know that you're looking at something more. Now, this is our checklist that we follow in a routine if we are looking at binder's phenotype with a skeletal malformation or any other abnormality on scan. We see all the long bones. We see the hands and the feet of the baby. We see the spine, the skull, the face for all of these things. We see the thorax. We see the fetal movements, very, very important. And we complement all our scans if there is an anomaly with a fetal echocardiography. Okay, so we've discussed about familial trait, vitamin K deficiency, about Down syndrome, syndromic etiology. Let's move on to chondrodysplasia punctata. Now, chondrodysplasia punctata is actually the main differential for binder's facies. And this is the most important differential for binder's facies. What happens here is there is a deficiency of an enzyme called ARSL. This enzyme, ARSL, is very, very important for skeletal development. And this is again linked to vitamin K metabolism. In chondrodysplasia punctata, as the name suggests, and what it means is that you get premature and disordered calcification within the cartilage where it should not be seen, and this is known as stippled epiphyses. There are a lot of types of chondrodysplasia punctata, but as far as ultrasound is concerned, we see three things. We see whether it is non-rhizomelic or the bones are normal in length. We see whether it is rhizomelic or it is a frank and severe micromelic variety of chondrodysplasia punctata. Let me take you through an array of cases here. Case number 1, micromelic chondrodysplasia punctata. You see an obvious binder's phenotype here. You see short long bones, a very, very short femur, disordered ossification center at the proximal epiphysis site. You see a very short femur. On biometry, the humerus, again, very, very short. And you see disordered ossification sites here and there. Also, just a minute. Yes. And also you see the phalanges as brachytelephalangism. These are short and stubby fingers which signify that I'm dealing with chondrodysplasia punctata, in fact. All right. Are there any marks on my screen, is it?
Yeah, Dr. Metan, you'll have to
I'll just
disable
end the...
annotations for others.
Yeah, exactly. So I will just end the
Yeah,
presentation.
stop sharing, share again, and
Yes, because I tried changing
yeah,
the...
no, it won't go. It won't go. Before you start the speaking, just say disable annotations. It's on the top controls.
Is it okay now, Rachita?
Yeah, now it's fine, but still disable. Otherwise, every time somebody touches the screen, you'll have a line.
Yes, because I think I'm not touching the screen, but
Yeah, it's others. It's others. Go up to
I'll
those floating controls.
Oh, well, right, this one annotate, right? And I just close it, is it?
No. In the floating controls above, you go into those three dot, the kebab menu, and say disable annotations for others.
This one here, is it? Because I have a lot of and all right, I can go on probably with these
Yeah, there's
annotations.
another line already.
I know. There's probably 10 minutes
Dear
more than...
delegates, please refrain from touching your screens.
Please don't touch your screens if possible, as much as possible, but just cases now. So because I thought I was
Stop
doing it.
share and reshare again. This line will go.
All right, wait now.
Yeah.
Done, is it?
Yeah.
Better?
Yes.
I hope nobody touches their screen now as far as I'm going on. All right. So the same case here, we see coccyx, we see altered limb position, we see these tarsal bone ossifications, and this in fact turned out to be a chondrodysplasia punctata, very severe form and likely pathogenic for mutation and homozygous as well. Case number 2, rhizomelic chondrodysplasia punctata. We see an obvious flattened face, binder's phenotype, dug in nares. We see a short femur. We see these epiphyses which are stippled. Again, fingers is something that we miss. Short and stubby fingers is something that we miss. And here we are seeing carpal bones as well as brachytele phalanges. We are seeing tarsal bone ossification here and in this video as well as a narrow thorax. Case number 3, rhizomelic chondrodysplasia punctata. Again, binder's phenotype, not so severe. However, the bones were very, very short. There was disordered ossification centers almost everywhere. These are autopsy images showing you very, very short bones, a rhizomelic variety, and X-ray of the baby as well, showing all these stippled epiphyses almost everywhere in the appendicular skeleton. Another case of chondrodysplasia punctata, nothing new, binder's phenotype, tarsal bone ossification. We have disordered ossification here as well. And there's a short femur, again, to complement our diagnosis. case of micromelic chondrodysplasia, again, very, very short bones, humerus also showing ossification, and distal epiphyseal disordered stippling everywhere. Now, this is a case of non-rhizomelic chondrodysplasia punctata. That means the bones were normal in length. However, we had stippled epiphysis and we had a binder's phenotype. The nose was dug in, the PMT was squared off, yes, although the hands were absolutely normal. Only the epiphysis of the proximal femoral end showed ossification and tarsal bones were seen. Non-rhizomelic chondrodysplasia, again, we have a very, very obvious binder's facies. We have coccyx that is seen, tarsal bone ossification, but a normal femur and normal long bones along with. This is an early presentation, early pickup of binder's facies as early as 14.2 weeks of gestation. We saw binder's facies and we saw tarsal bone ossification. Again, binder's phenotype only with normal bones and normal skeleton, just the face that was slanting, the PMT sort of squarish, yes. The 3D was evidently showing a flat nose. However, the femur was normal. There was no epiphyseal stippling and the humerus as well was normal. How do we counsel patients of binder's phenotype? Now, isolated binder's phenotype as my first case carries an excellent prognosis. They have favorable long-term outcomes. The sense of smell is not affected. The intelligence is completely normal. There's a 5% risk of hearing defects, but you can limit it by following Dr. Alpesh and getting all those tympanic rings and beautiful ears on scan. 5% risk of non-specific congenital cardiac defects. That is why we complement all our scans with a fetal echo. In severe binder's phenotype, a facial defect can lead to obviously functional as well as psychological issues, not just for the baby, but also for the family. What all is recommended? A multidisciplinary approach. Please keep a pediatrician in hand, geneticists, fetal medicine experts, as well as surgeons. Postnatal outcomes are dependent on how good the orthodontic intervention is, whether or not surgery is required in the form of rhinoplasty or Leafort's osteotomies, etc. And timing of interventions again is decided how the face of the baby is growing. Post-operative care, also monitoring complications for favorable outcomes. A word about Binder's syndrome, because we've discussed the whole circle, only Binder's syndrome is left. Again, Binder's syndrome has a different omen, has a different mode of inheritance than chondrodysplasia punctata. It is a different, an entirely different entity on its own. There is maxillonasal dysplasia, which means that you'll have a Binder's phenotype, malocclusion, terminal phalangeal hypoplasia of the hand, again brachytelephalanges. You might have vertebral clefting, nasal hypoplasia, as well as hypertelorism. How do I tell these two apart? Ending on a lighter note, sometimes same but different. I cannot tell on scan whether it's Binder's syndrome or it's chondrodysplasia punctata. I can label it as chondrodysplasia punctata because it is disordered ossification. But whether it's Binder's syndrome, Stickler's syndrome, or any other syndrome for that matter, has to be decided and taken over by a geneticist. I know there'll be a lot of questions for me in the chat box, but here are some questions that I thought of when I was making this presentation. Now, a lot of hoo-ha about vitamin K. So should we perform a prothrombin time and a PIVCA for every patient of hyperemesis? Any patient who has hyperemesis, documented hyperemesis, should we do a vitamin K level in those patients? Should we start supplementation of vitamin K in every patient regardless, like folic acid? We don't know, maybe in future. Should we worry about hypervitaminosis if we go ahead with supplementation of each and every patient with vitamin K in pregnancy? Should we screen for the ARSL gene, aryl sulfatase gene, in every CDP? Should we offer WES for every patient of CDP? Again, a geneticist's forte. Should we offer invasive for every Binder's phenotype, or should we just say that it may be familial? Should we take a chance with a familial trait and just let it go? Is there any way to diagnose maxillary hypoplasia prenatally? Do we have any values, any sort of measurements to diagnose maxillary hypoplasia prenatally? Should we report calcaneal ossification? And we are seeing it in the first trimester very, very commonly. And if you see an increase NT or an unossified nasal bone, you are going to see a calcaneal dot right there, right in the first trimester, 12 weeks of gestation. Should we be reporting it and seeing the face later on for a probably developing binders? Should we report calcaneal ossification and expect the patient, just because of our report, to see her again for any malaline, any face and any facial abnormality? Well, these are certain points that I thought of, which I think we're going to probably work on some maxillary hypoplasia, something about maxillary hypoplasia prenatally. And I thank you for a very, very patient hearing. Namaste and Jai Hind.
Thank you, Dr. Meetan Preet. Congratulations for such a lucid talk on a topic that always is very, very perplexing, not only to beginners, but even to experts. And you brought a lot of clarity to it. This has been really amazing. Just don't go anywhere because you will have some questions to answer. The chat box is full of those questions. Please go through them. So this has been a really remarkable evening because once when Dr. Khurana proposed that we should host this next gen webinar series, we knew that it's going to be successful, but we never knew that there will be such a phenomenal response. We had 500 attendees, the capacity was full, and many of the delegates who wanted to join, but they could not join because the capacity was full. They personally messaged me that they were not able to join. So I think Vishal and Conferences International, I think we need to increase our capacity so that more people can join. This has been very exciting, a very, very detailed take on the fetal phase, where our next gen experts, they shared their insights on very, very niche topics. But naturally the chat box is full of questions and we would like to go through them one by one. Khurana sir, if you're there, if you can, if you want to say something. I think today he's very, very busy. This is the week preceding the fetal basicon, and he's extremely busy preparing the program and other arrangements. So I think I will handle the question answer sessions as well. So Rachita, the first question goes to you. And
I've answered the questions in the chat box only, but I'll repeat, sir.
yes, I think you must repeat for the audience as well. So the Sivasamy sir is asking, can microphthalmia be evolving and not seen in an anomaly scan and seen later in the pregnancy?
Absolutely. Just like a cataract, even the size of the globe need not grow as much as it's expected to grow. Especially in cases of infection, it depends on the gestational age at which the infection occurred. So only after some 3-4 weeks of the infection will all the effects start to be seen. So we can have normal orbits in the first trimester and then see microphthalmia in the second trimester, or very rarely normal orbits in the mid trimester and then evolving microphthalmia in the third trimester.
Yes, absolutely correct. So normal eyes in the first trimester is not a guarantee that the eyes is going to remain normal in the third trimester as well. And what about retinoblastoma? Have you seen any case?
No, I haven't actually personally seen. They're extremely rare. I didn't include because I don't have a case in my collection and neither does Dr. Ramurthy. But it can be seen antenatally rarely, and it is a spectrum. Sometimes it's a very small soft tissue nodule along the posterior surface, along the retinal margin. Sometimes it can be huge, like a fungating fibrillar mass occupying the entire orbit. So it is a spectrum again, but it's extremely, extremely rare to pick it up antenatally.
Okay. Thank you, Dr. Rachita.
Thank you. Thank you,
You've
sir.
been really amazing as expected.
Thank you.
Alpesh, now
Yes,
the next
sir.
questions are for you. You have won a lot of fans, it seems. They're asking for your phone number. uh, so the first question that goes to you is that, this was a talk which was on the evaluation of the fetal ear on the ultrasound. So the question that is very often asked is how to evaluate both the ears. So any trick, because one can be seen easily, the other one is usually very difficult to get to. So what is your trick to get and evaluate both the ears?
So as soon as I get the dorso-anterior, I mean, with the evaluation of spine, I always start looking at the ears first. So I don't wait for the ears to come in position. As soon as I see the spine, I try to evaluate ears on both the sides. It hardly takes 10 to 15 seconds. Or even in the supine position also, sometimes we can see the ears as well.
Yeah, in the supine position, especially when the neck is hyperextended, you can
Yeah.
see ears easily just read from one side to the other. But yes, as you said that as soon as you get the section of the spine, start looking for the ears first, then you look at the spine.
Yeah.
And can we see the structures that you described on fetal MRI?
Fetal MRI usually is helpful in the inner ear abnormalities, which is not seen because of ossification of the petrostemporal bone. Yes, we can see on MRI as well the external pinna, but not as good as 3D ultrasound or on the 2D evaluation.
True, because on MRI, it is easier to see the inner ear structures, the semicircular canal, the cochlea,
And
etc.,
cochlea,
etc. But that too in the third trimester. In the second trimester, it is still
it's
very
also
tricky to.
difficult.
Yeah, it's difficult. But in the third trimester, it is fairly easy. Then the very often asked question is, how do you say ear is low set? What is the diagnostic criteria for a low set ear?
Low set ear, draw a line joining two dots. One is outer canthus, and second is the external occipital protuberance or the inion. And if the pinna is touching, the superior margin of the pinna is touching the line, or it should cross. If it is below that, then it is considered as low set ear. Or on the coronal section, you can see the level of pinna at the level of squamous suture. So these two ways we can conclude that the ear are at normal position or at are low set.
Yes, so the first method is easier to do on a 3D ultrasound where you
Yeah.
the line from the outer canthus to the inion.
Mm.
And the second method is better seen on grayscale imaging.
Yeah.
And then Dr. Chilappan is asking, when do you label it as a long philtrum?
Long philtrum, actually, there are nomograms available for each and everything, but it's actually a subjective when there is an increased distance between the upper lip margin and the columella. So we consider usually it is, and it has a convex outline. Then I label it as a long philtrum.
Yeah, so the way I see that, I see for long philtrum is that where the nose joins the lip, and from that point you measure till the tip of the nose.
Yeah.
And then from that point, you can also measure till the upper lip. And if this distance, the upper lip is longer than the nose tip, then we'll consider it as a long philtrum.
Yeah.
Okay, so this is one of the ways. Then there's another question by Dr. Hiral Shah that isolated pre-auricular tag, then what do you do when you see an isolated case of pre-auricular tag? Would you do genetic testing in such cases, and what else would you look for?
So isolated pre-auricular tags. So we have to first do a meticulous scan. We have to rule out any minor or major defects. If it is truly isolated, most often they are isolated. So I don't do anything. I mean, I just reassure the couple.
So in these cases, it is best to look for, facial asymmetry and other things
Yeah,
first. Okay,
that's
then
what I mean. If I am satisfied that whether it is isolated or it is associated with any other malformation like facial or cardiac or genitourinary.
true, these are actually very common. So
Mm.
usually do not cause any trouble. Now, what is the posterior rotation of the ear that you showed a case, and one of the cases which you showed.
So there are two ways. The vertical line should be parallel to the frontoparietal suture, but it's difficult to see. So we can draw a perpendicular line, which we talked about, the line joining from outer canthus to the inion. Draw a perpendicular line to that, and second line should be between 2 points, anterior superior point of the ear and the anterior inferior point of the ear, and measure the angle between these two lines. If it is less than, normally it is less than 20 degrees, but if it is more than 28 degrees, then it is considered as posterior rotation.
Yeah, so it's more of a visual impression rather than, you don't actually measure.
Yeah, you don't have to actually measure every time. When you see it often, external ear assessment you do often, then it becomes subjective interpretation.
Correct. And then the question that is inevitable, how do you look for tympanic ring?
Tympanic ring, actually in the paper and textbook, it is, there is a long, on the NPR 3D volume, but I find it is very tedious. I simply, I have shown one video as well, that during dorso-anterior, when the spine is anterior, I look for the ears in sagittal sweep, as well as in the axial sweep, I look for the tympanic ring with the VCI mode on. So the tympanic rings are very nicely seen as a round structure with the ossicles inside.
Yeah, I think it requires a bit of a practice and
yeah. Sometimes, after some time, it takes hardly a few seconds more, but there is a long learning curve for that also.
Correct. The baby has to be in a perfect position for identifying the tympanic rings.
But every time you need not to see about tympanic ring. When you see any external abnormality, external ear abnormality, then look for the tympanic.
That is true. Now, according to the ISWAP guidelines, there is only 1 year that requires evaluation. In fact, in ICRI guidelines also as well, we just need to look for 1 year. So why do we need to look for both the years in the context of routine fetal anatomy scanning?
Look, I have shown one case as well on the left side. If I would not have seen both the ears, I would have simply missed it, and there was no other abnormality.
Yeah, so this has been my experience also. In a few years back, I was in the habit of scanning just 1 year, and in that particular case, I was very happy with the ear I got. I did not make an effort to look at the other ear, but when the baby was born, and the baby had microtia on the other side. So, the patient does not really understand what is ISWAP protocol. The patient always says that it is something which is very obvious because they can see it very obviously. So they always feel that, it should have been seen. And it actually does not take much time to scan both the ears. So I think everybody should be in the habit of scanning both the ears rather than limiting themselves to just 1 year.
Yeah. And in one of the conferences, there was a discussion. So some senior fetal medicine specialists suggested don't miss any external abnormalities because this is very clearly seen to the parents, and this creates anger issues and sometimes violence as well. Even if you miss internal anomaly, that is okay, but never miss an external abnormality. So try to, try to include these things in your routine checklist as well.
Perfect. Very nice. So now the next set of questions is for Dr. Meetanpreet. Are you there, Dr. Meetanpreet?
Yes, I am.
Okay, so the question that is for you is, can Binder's facies be detected if nasal bone and the profile, they look normal? Just by comparing maxilla to globe or zygoma. Has it been your experience?
I don't think so. If I see a coronal face, yes, I can detect, as I've already elicited that if I see a dug-in nares and prominent cheeks and nose completely flat like this in the coronal view, I know 90 degrees turn, it's going to be a binder's face. But binder's face, as the name suggests, is because the nasal bone is verticalized and not horizontal.
Correct. So the go-to plane, in which we see the binder's face is the profile. And can delayed coccyx ossification hint at skeletal dysplasia with the normal long bones? You showed a case, the
Yes,
non-rhizomelic
so
ones.
coccyx should never be yes, coccyx should never be ossified prenatally ever. There,
Okay.
if it is ossified prenatally, then there's something wrong.
No, I think he has asked delayed coccyx ossification. My bad. Delayed coccyx. I don't see delayed coccyx ossification. You know, why should it matter? Because in the antenatal period, the coccyx does not ossify.
Exactly. So we are not
It's the early ossification that we are worried about.
should matter. So we have cases of early ossification or a premature ossification or just simple coccygeal ossification antenatally without binders as well. So that uh, can be classified into chondrodysplasia punctata because chondrodysplasia punctata essentially means disordered ossification, and coccyx can be included in that as well.
True, true. Now, how do we differentiate between stippling versus a normal ossification center difference?
So we have nomograms to objectify brachyphalanges, like short stubby fingers. We do
No, no,
have
no. The first question is this is just about the stippling versus normal ossification. But
stippling.
when do you say that it is a normal ossification center versus it has premature?
There is a skeletal timeline that we follow. We have it in our checklist, and we know when S1 11 weeks, S2 14 weeks, S3 18 weeks, and then distal femoral epiphysis 34 weeks. A normal calcaneum appears at around 20 to 23 weeks, and talus appears at around 25 to 26 weeks. So we know by that we have a skeletal timeline in mind, and we know what gestation we are seeing the baby at, so we know what to expect.
Yeah,
Anything marginally is not right.
yeah. So actually, we do not really see the stippling epiphysis. We see the premature appearance of the epiphysis. That is the clue for chondrodysplasia punctata.
Any of the long bone epiphyses which show one dot or multiple dots
Yeah.
is considered stippled epiphyses.
Stippled, yes. But stippling is fairly rare.
Yeah.
Premature ossification is far more common.
Yes. Yeah.
Okay, so the next question is how to tell brachydactyly on ultrasound?
Right. So the technique that I follow subjectively, I see the baby's thumb when I'm scanning for the hand, and if the fingers are of equal length as the thumb, I know the fingers are short and stubby. Secondly, we have nomograms from I think 14 weeks to 27 weeks, where they've given us 5th centile, 50th centile, and 95th centiles for these fingers.
And as an extension of this question, how do we say it's brachytelephalangia?
So again, short fingers for me is brachytelephalangism, and nomograms usually we open them once we get a case, but just by eyeballing, we get to realize that they're not as long as we expect them to be.
Correct. The distal phalanges of the fingers, they appear very, very short compared to the middle and the proximal phalanx, and that is the hallmark of brachytelephalangia. All right. So the important thing is that whenever we see such a case of binders facies, then we need to look at the hands very, very carefully. Okay. Then isolated flat facies, will the outcome be normal? And can we assure the parents to continue the pregnancy? Or if you see a case, would you always advise genetic testing?
As a recommendation in this era, I would advise it in this legal era. I would advise it to every patient, at least a basic CMA, because I cannot be sure whether it's familial. Even if the couple walks in with flat faces, I still have to offer. I will get my geneticist in loop, and I'll explain everything. That it looks like to be a face like yours, but I cannot be sure. There may be something underlying that I cannot be sure that may be picked up even later in gestation or postnatally.
True, because first, when we see the case first, it's usually the second trimester and the ossification centers, etc., etc. All these things they can develop later on as well.
Exactly, definitely. And it may be reverse. It may get better. Like for a lot of cases that we see binders, facies, we've given them off in the second trimester, and the patient walks in at 35, 36 weeks. It's actually a normal looking profile because the maxilla has grown very well.
Absolutely correct. Now, any take on coronal clefts of the spine for CDP diagnosis?
I'm still looking for it. On it. I remember Adi sir's. I'm a big fan of Adi sir, and he showed one case in one of his
Yes.
presentations way back, I think in Mediscan, and I can't forget that presentation with the coronal clefts, and I'm still waiting for it.
Then even recently he showed us a case of coronal clefts in the vertebral bodies, and but that was not associated with CDP as far as I remember. Okay. Then there are a lot of congratulations. Then what about the talus and the distal femoral epiphysis ossification at 9 months gestation?
So
Would you consider them as normal? Yeah, these are
yes,
normal.
of course. I've answered that in the again skeletal timeline. We have a small skeletal timeline, a photograph right next to pasted this thing in our clinic. We know that what gestation we are looking at.
And what is the prognosis in non-rhizomelic CDPs?
So again, a tad better than normal just binders phenotype if it is truly isolated, but obviously much better than a rhizomelic or a micromelic variety. But all of them, they usually do well.
Okay. Alpesh, if you're here, there's one question for you as well.
Yes.
Are there any nomograms available for measurement of the ears?
Yeah, I have shown.
Yes.
One is by Dr. Usha Chitkara, which was published in 2000.
Correct. Dr. Kurian is asking about the long filter measurement. I will personally message you. Don't worry. Dr. Manohar asking if there's a history of hyperemesis gravidarum in binders phenotype, can we skip any further investigations?
Again, like I've answered, it's actually a trade-off. You may label it as vitamin K deficiency, but you never know this vitamin K deficiency is actually due to that or any other gene which is mutated. So I think, testing should be offered from our side in this era to all couples.
Okay. And how often would you see corpal bone ossifications in CDP cases?
It is actually quite rare.
I have never seen.
Yeah, so it is very, very rare.
Yeah. And would you use the same angles, facial angles for diagnosis of CD binders facies in the third trimester?
Not really, because the baby and like I showed you, and that sort of pokes me every time I look at it. The angles, these ones have been described from 18 to 21 weeks only. So we, as a country with probably the binder capital of the world, we should probably do these angles and in later on gestation as well to find out whether they make sense in that gestation. However, the baby is really living in a compromised sort of space and everything's bent, you might not get a good angle and the baby moves around. So it doesn't make sense to do it after about say 28, 29 weeks of gestation.
And one more question for you. If you see fetus with classic binders facies, but normal limb and spine, nothing else, so can we still suspect there's some spine spondyloepiphyseal dysplasia with CDP?
See, anything can happen anytime. I've seen patients with binders first, and then they come back after about 4 weeks, and there are small little. I've seen faint stippling turning into a florid stippling, and really anything can happen in the world of obstetrics. If I'm seeing a classical binders facies, I do not know whether it's truly isolated until I open up the genetic makeup of the baby.
Yeah, I know it again, as I said earlier, it all depends on the gestational age. When you first examine the fetus, the rest of the pregnancy is still there, and the fetus can show many findings as the gestational age progresses. It's not that in the first setting itself you are going to see everything. Yes, so it is important that we need to evaluate genetically these fetuses, even if we see one isolated finding, which is a big finding actually. Okay, Dr.
I think, sir, may I add one point?
Yes, please.
Wonderful presentations by both Dr. Alpesh and Dr. Meetan. Extensive, beautiful case series. I think most of the cases have been, should we offer invasive? Should we offer invasive? Yes, it is our duty to offer invasive. Whether they do it or not is left up to them. We know that these certain disorders need to be ruled out, and we can do that only by genetic testing. So put it in writing, put it in print in the report saying binder facies, maybe no other recognizable ultrasound evidence of chondrodysplasia at present, but we need to check genetics, go molecular. And if there's only one test that we should choose, or if the patient can afford, offer a whole exome sequencing. A whole exome sequencing will cover all the single gene mutations. It can also cover copy number variants. Now, most whole exome sequencing, they do what is called as a copy number variant calling, CNV calling. So if there's any micro deletions, micro duplications, the exome sequencing itself will report it. You don't need to do a chromosomal microarray separately. So the whole exome sequencing will actually cover everything. And most of the time with whole exome sequencing, we always add a QF-PCR for 13, 18, 21. So that will cover at least the downs and the basic trisomies. So offer it. And more important than anything, whether they do an invasive testing or not, please, please encourage the couples and reassure them and tell them that they have to continue even if they don't want to do a testing. So many fetuses are being aborted just for a binder facies. Most of them we know will turn out normal. CDP is rare. The genetic mutations are rare. So even if they don't want to do invasive testing, please encourage them to continue. And at least in our practice, I think if we have done about 100 invasive testings for binder facies, we've picked up genetic disorders in maybe 5 or 6. That's how rare it is. So I think that is what we can offer them, reassurance, and ask them to continue, and that will actually be saving a lot of normal lives.
Wonderfully summed up, Rachita. Wonderful.
Yes, and today, the cost of doing a whole exome sequencing, it is also falling. It's very
Absolutely.
comfortable actually. So
Absolutely.
I think it should be offered more and more. Now, one last question for Dr. Neetan Preet. How about the hillside residents with flat nose for binders? What will be your take?
So we've seen a lot of hillside residents. I don't think they have that typical binders profile. Once you see a binders profile, you know you're looking at it. And hillside, non-hillside, I don't think makes such a huge difference.
Yeah, true. Okay, so when we see a finding, we'll assume it is, first we'll assume it is abnormal. Okay. Normalcy has to be truly brought out by doing testing and other things. One more question for you, Dr. Alpesh. This will be the last question. So, can microtia with normal outline and anatomy? Alpesh, you need to unmute.
Yes, grade 1 microtia. Only the size is small, but the outline and the morphology is normal.
That is true. That is true. So, Khurana sir is here. Any closing remarks from you, sir?
This has been so fascinating. I don't even have words to express how impressed I am with the quality of presentations, with the fabulous presentations by Rachita, by Dr. Alpesh Pancholi, and by Neetan Preet. And I don't think it's just me who endorses the fact that this is fascinating. We were full house and we couldn't fit in anymore because our Zoom meeting got full after ages and ages. And I think, therefore, we're in the right direction. I want to congratulate the speakers for their phenomenal presentations. These are way ahead of world class and really puts our Society of Fetal Medicine way ahead as the best organization. And I thank you, each one of you, for being a part of it, if you are a delegate or an attendee. But I especially thank the speakers for taking this so far. I also want to congratulate Dr. Alok Varshni for having first conceived of this idea and then taking it forward. And so we really look forward to traveling the high horse, if I may call it that. And thank you, each one of you, for making it so successful.
Thank you. Thank you, sir. Thank you,
you,
Dr.
sir.
Alok. Thank you, Dr.
Thank you,
Ashok.
sir. Thank you so much. You have always been an inspiration, and you are very generous that you say that this was my idea.
Of course it was.
All right, but I know that it was your idea in the first place. Okay, let's call it an evening. This has been very, very exciting. Thank you, Vishal. Thank you, Conferences International. Thank you, all the delegates, for you have been very, very patient And your attendance in such large number, it is what propels us to find out more next gen speakers, more niche topics. And we'll be seeing you next month as well for another webinar in this same series. Good night, everyone. Thank you.
Good night. Good night. Thank you. Thank you, sir.